Good evening, ladies and gentlemen. I would like to call upon President Ma'am on dais, Dr. Nandita Stogi Ma'am, Honorary Secretary Sir, Dr. Vikas Mr. Boss, Dr. A.C. Gawal Sir, and Chairman, he is Chairman to Scientific Subcommittee. And our speaker, Dr. Puneet Puri Sir. I would request to call on the dais.
May I have the honor to present the presidential caller to Honorable President Dr. Nandita Stogi, ma'am.
I call the CME to order.
Thank you, ma'am. I would request President Ma'am for the welcome address.
Respected seniors and dear friends, this is going to be our last CME for this tenure, and we have again kept a topic which is very clinically relevant. I don't think any doctor who's doing clinical practice has not faced the problem of gastroesophageal reflux disease. We've been treating with antacids and all the omeprazoles and the pantoprazole for many years. But now, sometimes when the patient does not respond, there are better modalities which we are going to learn from our very learned speaker, Dr. Puri. And we are very happy to have Dr. Puri in our IMA, one of our very own. And I'm sure we'll all be benefited by today's deliberation in our clinical practice. So thank you, Dr. Puri, and thank you, Dr. Kirti, for arranging this CME.
I would request Dr. Piyush Mishra Boss, Senior Consultant Gastroenterologist, to kindly introduce the subject.
Hello. Very good evening. We have a very nice topic today. Basically, a simple word is, today's topic is heartburn. We have a wonderful surgeon, a great gastrosurgeon speaking on this topic. This is going to be a very enlightening talk. I am sure every physician, whoever has done MBBS and who is doing practice, has faced this patient of heartburn. So I invite Dr. Puneet Puri to start his talk on GERD.
Thank you so much, Dr. Piyush sir. And before I invite the eminent speaker, may I have the privilege to request our moderator, Dr. Kirti Vardhan Singh, to kindly introduce our eminent speaker, Dr. Puri sir. And I request respected Honorable President ma'am to please come and chair.
Today we have eminent speaker Dr. Puneet Puri Boss with us. He has done his MBBS from GMC Patiala, his MS in General Surgery from SM Sawai Mansingh, and his MCH from GI Surgery. He has done completed from SGPJ Lucknow. Presently, he is working with RS Hospital Kanpur and KMC. Previously, he was working with Regency Hospital Kanpur. He has a very great career and he has performed many surgeries, successful surgeries. So I request upon Dr. Puneet Puri Boss to deliver the talk. Sir, please.
Good evening, all my seniors, colleagues. I extend my heartiest thanks to my IMA family as well as my Sun Pharma group for providing me this opportunity to discuss such a beautiful and a very common topic, as this has already been told by Piyush Boss that no doctor will be immune to patient of GERD. So, if we talk about the spectrum, this may be an occasional problem. One might feel occasional heartburn once in a while, but the spectrum is very wide. The symptoms may persist from mild, they can extend to moderate severity, and some they can lead to pre-malignant conditions, and eventually cancer can develop in patients with GERD. So if we talk about severity, if the symptoms occur once in a while, less than in a week, they are called as mild GERD. If few times in a week, they are moderate. And when there are extra symptoms like dysphagia and there is cough, there is change in voice, there are sleep disturbances, this is known as severe GERD. And when persistent GERD for a long-standing time, there are changes in the mucosa, there is evidence of metaplasia and then dysplasia, there is evidence of Barrett's esophagus, which eventually turns out to be a malignancy of the esophagus. This is the natural course. Once over a time, this was considered to be a disease of West, but it is not so. There is a surge of up to 77% in the last 3 decades from 90s to 2019. And GERD is basically divided into 2 types on the basis of endoscopy. One is erosive gastroesophageal reflux disease, and another one is non-erosive. Short form we say NERD. And most of the patients, up to the tune of 70%, they don't have any structural changes and they belong to the class of NERD. If we talk about prevalence in India, this is from Indian study in 2024 and 2019. GERD prevalence varies from 7 to 30% in various studies. So this is a heterogeneity in the prevalence itself. But if we talk about pooled prevalence, it is somewhere around 15%. And this is why so much variability, because of the different symptoms consideration. Heartburn, as I already been talked about in the beginning of the talk, this is the commonest symptom of the GERD. What are the risk factors and causes? The list is very long. There are few lifestyle issues like obesity, eating habits, large amount of food intake just before sleeping, late night awakenings, and pregnancy, hyperprogesteronemia. These are lifestyle diseases. Food intake, carbonated drinks, caffeine intake, and there are few diseases which affect the motility of the esophagus, which affect the relaxation of the lower esophageal sphincter and the motility of the stomach, that is gastroparesis, along with a very, very important disease, that is structural disease, that is hiatus hernia. Hiatus hernia is one such structural issue which augments the occurrence of GERD. And there are a list of medications which can reduce the sphincter tone, or it can increase the relaxation of the lower esophageal sphincter. So these are the various risk factors. If we look at this diagram, the esophagus is meant only for the passage of food. It cannot tolerate acid. Acid is formed inside the stomach, and when there are problems with the sphincter, or there are problems with the motility of the esophagus, that it is unable to clear the reflux acid, that is impaired esophageal acid clearance, then there are structural changes in the esophagus in the form of erosions, ulcerations, and that is known as erosive GERD. Along with that, if there is delayed gastric emptying, that the stomach acid persists in the stomach for a very long time, then there is a probability of GERD. There is some concept of acid pocket, that this area just distal to the GE junction, this is very much low in pH. This is the area of acid pocket which has been documented endoscopically by pH manometry studies, that this area, antropyloric region and the body, it has the pH of 5 to 6. But distal, in the proximal portion, this pH drops to 2. This is very acidic. So if we talk about etiology, there are so many non-modifiable risk factors like lax sphincters, there are persistent relaxation of the sphincter, or there is poor mucosal protective mechanism and hiatal hernia, but some of them are modifiable also, like drugs, smoking, obesity. Obesity is specifically related with the reflux when it alters the angle of His. So talking about symptoms, GERD, the most common symptom is heartburn. There is burning sensation in the retrosternal region. And sometimes patient describes that food is also sticking while passing through the esophagus. Second important symptom is reflux. This reflux is effortless regurgitation of acid or food. But there are n number of atypical symptoms of GERD also, and like orodental symptoms, oral ulcer, dental caries. Many patients, they don't report to gastrophysician or gastrosurgeon directly. They go to ENT surgeons, pulmonologists, cardiologists, because these symptoms, they mimic the respective organs. Like micro aspirations of the acid and food lead to chronic cough. Sometimes pneumonitis also, aspiration pneumonitis. Sleep disturbances are also very common in patients with atypical symptoms. If we talk about complicated GERD, a GERD standing for many years, there are structural changes, erosive gastritis, erosive esophagitis, melena, and whenever there is stricture formation because of the fibrosis, then starts the problem of dysphagia and orinophagia. Believe me, dysphagia in the setting of GERD can be because of the peptic stricture, or there can be an underlying malignancy. So one should definitely distinguish if it is a recent onset dysphagia without preceding GERD, one must rule out malignancy first. If there are symptoms of GERD for many years and then there is dysphagia, obviously the endoscopy is warranted and we should take biopsy. Another alarming symptom is weight loss in patients with GERD. That is also an indicator of complicated. If we talk about diagnosis, various guidelines they have said endoscopy is not the first line of investigation in patients with GERD. Even the trial of PPI, if it relieves the symptoms, that also establishes the diagnosis of GERD. Most important thing is the history. When it is happening, how many times it is happening in a week, what is the association with food, and important thing is 24-hour pH manometry. If we calculate the pH in the esophagus, it is not simply the pH of the fluid, because I told you the reflux is of two things. One is acid as well as food. If there is a food reflux, the pH manometry will not tell anything. So we have added impedance to it. So even if the solid food comes into the esophagus, because of the change of the impedance, there will be changes in the pH manometer. So this is the gold standard for establishing the diagnosis of GERD. Endoscopy. As I told you, most of the patients of the GERD, 60 to 70%, they are having non-erosive disease. Means there are no structural changes in the esophagus. So endoscopy will be absolutely normal in those patients. Only those patients who have erosive esophagitis, that is basically guided by the Los Angeles classification from grade A to grade D, so they will be picked up on endoscopy. So it means a negative or a normal endoscopy does not rule out the diagnosis of GERD. But yes, if there are evidences present that establishes the diagnosis of erosive GERD. Biopsy, whenever there are suspicious lesions, we must biopsy them. And upper GI contrast study, it has a very limited role in the establishing the diagnosis of GERD, but yes, it is helpful in ruling out few few diseases which are acting as differential diagnosis. So what is the differential diagnosis? If we talk about these three things, reflux of food with heartburn and dysphagia. So anything apart from GERD, can anybody suggest? There are three symptoms: reflux of food along with heartburn and dysphagia. So very important differential diagnosis is Plication cardia, because all the three symptoms can happen in it. Because reflux of undigested food can happen, and the food is accumulating into the esophagus, and there is fermentation of the food which can lead to heartburn, and obviously there is dysphagia, which is the primary symptom of Plication. So how we will differentiate? With the help of manometric studies. And upper GI contrast study plays a very important role. This is a picture, classical picture of Plication cardia, where we see there is dilatation of the esophagus with narrowing in the distal end, bird beak appearance. And believe me, if you offer any sort of surgical therapy in these patients thinking that these are patients of GERD, you will land up into disaster. So what are the treatment goals of managing these patients? One, whatever therapy you offer to the patient, your goal should be to elevate the symptoms, the reflux incidence should reduce, frequency should reduce, and we should prevent the complications, and obviously the recurrence should be prevented. Last but not the least, we must address the underlying cause of GERD. So lifestyle modifications, so many things have been told, but we don't have any level 1 evidence in the literature. But yes, there are recommendations for lifestyle modifications, like we should avoid large meals, spicy meals, we should not lie down immediately after meals, smoking, alcohol should be abundant, and headed elevation of the bed can be offered to prevent the reflux, and obviously the weight loss. So if we talk about medical management, that was the topic, pills to plication. So first line of medication was H2 receptor blockers, that is histamine receptor blockers, cimetidine, ranitidine. But once the advent of PPI were done, this have removed the use of H2 blockers in the clinical practice. Now the commonest drug used is PPIs till date. Omeprazole was the first drug, and the list is long: esomeprazole, lansoprazole, dexlansoprazole, pantoprazole, rabeprazole. These drugs, they are focusing on the reduction of acid by inhibiting the hydrogen potassium ATP pumps in the parietal cells of the stomach. Hence, once the pH is increased, the symptoms of reflux are controlled to a great extent. Another class of drugs like prokinetics, like dopamine blockers or serotonin agonists, they enhance the motility of the stomach, hence helpful in patients with gastroparesis. Antacids. Antacids just coat the surface and they neutralize the basically acid to make the pH in alkaline range. Recently, a newer class of drug is PCABs, that is potassium competitive acid blockers. The entire pharmaceutical companies are, running after the marketing of this class of drugs, may it be vonoprazan, fexofenazine, tegoprazan. So these are potassium competitive acid blockers, which block the this hydrogen potassium ATP pumps, whether they are active or in resting state, and they have few advantages I will talk about. And another class of drugs useful is baclofen, which can help in inhibiting the reflux. And surface coating agents, they are especially helpful in erosive esophagitis because they coat the surface and of the lesion, and hence they prevent the detrimental effect of the acid happening in the esophagus. So if we talk about limitations, so limitation of proton pump therapy is usually the onset of the action is delayed. Not the single drug will be effective, single dose will not be effective. It will take at least 3 to 5 days for the full action to happen. Multiple doses are required, and there is mealtime dependency also. If we take the PPI half an hour before the meals, only then they are effective. And there are genetic issues for the metabolism like cytochrome P450 group of enzymes. So there is variability in the genes, hence causing variable effect in the patients with GERD. So if we talk about the duration of PPI, for how long we should use PPI in patients with GERD. So American College of Gastroenterology 2022 guidelines, they say if the symptoms are severe, you should use for at least 8 weeks. If there are associated extraesophageal symptoms like pulmonary symptoms, cardiac symptoms, the duration should be up to 12 weeks. But World Gastroenterology Organization and Chinese, Korean, Japanese, these guidelines, they recommend the duration of PPI therapy up to 6 weeks. So what is persistent GERD? There are ample of studies which are telling that despite use of adequate PPI therapy, there are patients up to the tune of 40% who show partial or no response to PPI therapy. So there is a study in 2024, American Journal of Gastroenterology, which says 10 to 30% of the erosive esophagitis patients, they fail remission despite giving PPI therapy for 8 weeks. So same is true in NERD. 50% patients they don't respond. Only 50% they respond with the PPI therapy. So what is the Indian perspective? The study by the Indian researchers and Dr. UC Ghoshal from SGPGI, they said 40 to 70% they face nocturnal acid breakthrough, even when they are on PPI therapy. So this is very important aspect. What is NAB, nocturnal acid breakthrough, is when there is certain severe heartburn at the night time. So it is a major unmet need in the management of GERD patients. Daytime they will be fine, but during night time there is massive reflux of acid, and it affects their sleep, and so it leads to problem for the next day. They are not able to perform well in the next day. And 70% of these patients, they use over-the-counter medications like any Udin Hara, any antacid gels, but only less than 30% they get relief. Another problem with PPI is drug interactions. In today's world, we have patients with many comorbidities, especially the cardiovascular comorbidity patients, when they are on dual antiplatelet drug therapies. So the problem with clopidogrel is enormous. On one hand, we are prescribing them dual antiplatelet therapy. There is risk of GI bleed, and if we add PPI to them, then there is chances of failure of these platelet drugs, so leading to MACE, major adverse cardiovascular events. Similarly, these PPIs, they have adverse reactions with statins. And if we use the these PPIs for many years, so there are many theoretical risk factors which are now being studied in various clinical subset of the patients, and these things have come up, that rebound acids hypersecretion, dysbiosis, SIBO, hypomagnesemia, multiple vitamin deficiencies, interstitial nephritis, kidney issues, and more than 5 years of use they have been associated with cirrhosis of the liver also. Yes, PCABs, to some extent, they are helpful in overcoming some limitations of PPI, like onset of action. With single dose, the effect is immediate. And they block the resting as well as the active hydrogen potassium ATP pumps. And there is no interaction of food. You can use these drugs at any point of time. But these are the recent drugs. We don't have adequate studies on Indian population. All the companies, they are coming to us, they are just showing Japanese data. What have been their response? Japanese population, they have different genetic makeup compared to the Indian populations. We cannot extrapolate the data from them and enforce on our population. So till now, what we have learned is the major focus was on to the reduction of the gastric acid. But if we recall, the basic pathology in GERD is incompetent lower esophageal sphincter, or we can say it is a faulty flap valve mechanism. Till now, no drug is focusing on this issue. So if I talk about surgical management, the basic surgery is based on this principle that it aims at correction of faulty valve mechanism. Secondly, there is correction of pressure dynamics. If we talk about chest and abdomen as separate cavities, thorax is a cavity with negative pressure, whereas the abdominal cavity is a positive pressure cavity. If there is a displacement in GE junction, if it is migrated to the thorax and the lower end of the esophagus is lying already in the thorax, it is altogether in the negative zone. So chances of reflux will be high even with the slightest relaxation of the lower esophageal sphincter. So now coming to the surgical management. Whom should we offer surgery? All are patients the candidates for surgery? Answer is no. So this is the list. When there is failed response to the medical therapy, despite giving best of the best PPIs along with the another combination of prokinetics, surface coating agents, patient is not having any relief. So these are the subset of the patients who need surgery. Or there is a partial response. Patients who have complicated GERD, like GI bleed, or stricture, Barrett esophagus, or patients having malignancy, obviously there is no role of medical management in these patients. Complications of the medical therapy in the form of vitamin deficiency, bone disorders, kidney disorders. So these are the patients who also qualify for the surgical management. Associated large hiatal hernia. There is no question of offering these patients on BPA therapy for many years. If you have diagnosed a hiatus hernia with GERD, this is the patient who needs surgery in the first go. And patient preference. In my clinical practice, we have seen many young patients in the second decade of life are suffering from GERD, who are not responding to the medical management. Or this is a patient preference, they don't want to take medications for lifelong. So you can ask them to undergo surgery because it is one shot treatment for GERD, and there is no need of medications after the surgery. So if we talk about surgery, what surgery do we offer? So basic surgery is fundoplication. But as I told you, we have to correct the pressure dynamics. The most important thing is there should be an adequate length of esophagus in the abdominal cavity, and around this abdominal esophagus there should be a wrap of fundus only, fundus of esophagus, fundus of stomach, not the body, because otherwise there will be disparity between the motility. And there are various types of the fundoplication. The commonest is Nison's fundoplication. This was first attempted way back in 1955. But at that time, this surgery was offered by open technique. But since the advent of laparoscopy in the 1990s, now this surgery is being done with laparoscopic route. If we talk about the rest of the spectrum of APD, like surgery for gastric ulcer disease or gastric outlet obstruction consequent to peptic ulcer disease, there is a drastic reduction in the surgical procedures over the last 30 to 40 years. During my residency, I have seen only 1 or 2 cases of truncal vagotomy, but during my entire practice, I have not performed even single one. Why so? Because PPIs are very effective in controlling the acidity part, hence improving the ulceration part and treatment of the gastric ulcer or duodenal ulcer. But as far as reflux is concerned, simply reducing the acid amount is not going to treat the reflux. Still, you can prevent the acid reflux, but what will be done for the food reflux? So, this surgery of fundoplication, they are on the search for the last 3 decades, because more and more patients with reflux are now being diagnosed and they are getting relieved with the surgery. So, obviously, when we are talking about fundoplication, we have to dissect the esophagus, we have to close the defect of the hiatus with the help of the sutures, and if the defect is very wide, more than 10 cm, then approximation is not possible, then we have to augment this defect closure with mesh, that is known as fluoroplasty. Only those patients who have stricture of the esophagus or who are having shortening of the esophagus, which is non-functional esophagus, then we can offer resective surgeries. So Nison's fundoplication is the gold standard procedure for surgical management of the GERD, and it is a 360-degree flap. I will not go into theory, I will show you a small video clip. It is done in general anesthesia. It is not a very big surgery, I would say. It is just like laparoscopic cholecystectomy. It is done with a minimal invasive method. There are few ports only, and duration is almost 1 hour under general anesthesia. 5 ports are used, and there is no blood loss. I will show you a small video. So this is the optical port entry into the abdominal wall. You can see the muscle, now the posterior sheet, and now we have entered into the peritoneal cavity. This is the left lobe of the liver, and there are multiple 5 mm ports are being placed. Just admitting one width of pen. So this one is the retracting port. First step is to lift the left lobe of the liver. So for persistent lifting, we may use various retractors, but in this case I am using a little modification. I am passing an umbilical tape and lifting the left lobe of liver. Otherwise there are various retractors, laparoscopic retractors available, which can lift the left lobe of the liver. So this is the triangular ligament on the left side. You can see the pulsations of the heart, and this ribbon shaped umbilical cotton tape. This is passed through the left triangle ligament, and the left lobe of liver is elevated. And you see this effect? This is the hiatal hernia. This one. And once the stomach is now being mobilized, we are dividing the gastrohepatic ligament. This is the pars flaccida portion of the gastrohepatic ligament. This is divided with this instrument. This is harmonic instrument. And I hope that we can appreciate this brownish, reddish brownish structure. This is the right crust of the diaphragm. Right and left crust of the diaphragm, they form the esophagus hiatus. So first step is to dissect off the esophagus from the right crust. So we are separating the right crust from the esophagus. Gradually, now the dissection is shifted to the greater curvature. Because of the long-standing hernia, you see such a wide defect, the stomach is adherent to the edges, and now the fundus part of the stomach is being mobilized by dividing the gastrosplenic ligament. These are the short gastric vessels which are being divided with the help of harmonic scalpel. And this mobilization should be adequate because we are supposed to make a wrap of this fundus around the esophagus. So these are the dense adhesions because of the long-standing hernia. And if you can appreciate this whitish structure, this was the phreноesophageal membrane. This one. So gradually we will, this one is the phreноesophageal membrane and part of pleura. Gradually we will encircle the esophagus. So the junction of right and left crust has been lifted, and now we are working into the thoracic cavity. So this is thoracic cavity. Esophagus is being dissected off from its periesophageal material. This is the pericardial material. This one. And soon we will realize the presence of the vagus nerve. We should not damage the vagus nerve. This one is the vagus nerve. This one. Vagus leads to the acid production due to cephalic phase, as well as it offers the motility to the stomach and leads to the relaxation of the pylorus. So this esophagus is mobilized into the thoracic cavity, and gradually we will drag this esophagus down into the abdominal cavity. So the umbilical tape again has been wrapped around the esophagus and it will be lifted, so it aids into the dissection of the esophagus. Now again into the thorax. So once an adequate length of esophagus is mobilized, only then we should do the chlorotherapy or chloroplasty. So now this one is the right crust, this is the left crust. This gap is now being approximated with the help of an epithelial suture, and the assistant has lifted the esophagus up. So both the crura will be approximated so that the stomach should not migrate again into the thorax. And this approximation should be very, very gentle. Otherwise, it can lead to cut through of the muscular fibers and your repair can fail in the future. So just approximating the right and left crura with the help of interrupted epithelial suture. This is delayed absorbable suture. One should be very careful in approximating this crura. If you apply sutures too close to esophagus, it can lead to problem of dysphagia. So there should be some loosening at this region. You should not, the last suture should not snugly fit onto the esophagus. So once the chlorotherapy has been done, this is the fundus of the stomach. So now we are taking this fundus from behind the esophagus onto the right side. So now this fundus, this is the fundus which has been brought to the right side. Yes. And it should not go back. This is known as shoe shine maneuver. So it basically reflects that there is adequate mobilization so that it can encircle the lower esophagus. So now with the help of silk suture, silk suture, we take the seromuscular bite from the fundus, adventitial bite from the esophagus, and we do a fundoplication. So basically this is 360-degree wrap of the fundus around the esophagus. This prevents the reflux that is the content of the stomach, will not go back into the esophagus. This is the basic aim of the surgery. So these sutures are applied, and again these sutures should not be very tight, otherwise dysphagia can happen. So at the end of the surgery, there is an option, you can place a drain, and as you have seen, there is hardly any blood loss, and these patients, they are done under general anesthesia. Duration of surgery is almost 1 hour, and there are only 5 ports. 4 of them are 5 millimeter, and only 1 port is of 10 mm. So post-operative care, it is as similar to laparoscopic cholecystectomy. You ask the patient to get up after 2 hours. He or she can go to the washroom to pass urine by him or her own. Liquid diet is started on the same day. Next day patient is allowed to have soft diet, and he or she can resume his or her own work in 48 hours. So that is the beauty of minimally invasive surgery. If we talk about complications, is the surgery devoid of complications? Largely yes. Complications happen in less than 2% if the surgeon is inexperienced, or there are pathological problems like the stomach is very badly triggered to the wall of the hiatus, or it is adherent to the spleen. Then there are problems of bleed, splenic injury, injury to the short gastric vessels, or inadvertent injury to the stomach wall itself while using the harmonic. These are few problems which can happen if you don't pay attention while mobilization of the stomach. A late complication, yes, if you have very tightly closed the hiatus and it breaks through subsequently, then there is a migration of wrap into the thorax. This can happen. You should never forcefully approximate the crura. If they are not coming together, place a mesh in between. Transient dysphagia. After surgery, there is obviously some edema, and after a few days, 4 to 5 days, patients experience some degree of dysphagia, which is usually self-limiting. We should counsel these patients. Otherwise, they will be afraid कि मैंने कराई तो surgery reflex के लिए थी, अब खाना भी नहीं खा पा रहा हूँ. So you should counsel them very, very carefully that this will happen and it will go by its own. What are the benefits? It's very safe, effective method of treating this problem, and as I told you, it is cosmetically acceptable, minimal length hospital stay, least morbidity, and most important thing is there is no need of lifelong medications. So what are the latest advancements? Still there are advancements in the management, surgical management of this GERD, that is robotic assisted anti-reflux surgery. This is now being done in our city. Magnetic rings, bracelets are also available which we can place surgically around the lower esophageal sphincter. It is a specific management system, links management system. There are titanium beads. There is a bracelet which can be placed around the lower esophagus. Once you eat food, these beads they move apart, and once the food goes inside the stomach, they again come close, and the reflux is prevented. And obviously, this is the last word is for Dr. Piyush Boss. The total incisionless fundoplication, which are now being done by endoscopically, these are also coming up. So, take-home message of today's discussion is GERD requires thorough evaluation. History is the first thing to be taken thoroughly. Normal endoscopy does not rule out GERD. Patients for surgery should be selected very, very carefully. And anti-reflux surgery is an anatomical and physiological care for these patients, and it is very safe and affordable, and obviously improves the quality of life. Thank you very much for patiently listening.
Thank you so much, sir, for such a wonderful talk. And I would request our chairpersons and panelists for expert comments and questions.
Wonderful talk, sir, and the wonderful demonstration of the surgery. The problem is that still many of the doctors and physicians, they do not know about the surgery which is being done for the GERD. And maybe in the Kanpur, most of the physicians know, I think, but the region around the Kanpur, they do not know the surgery, the name of the fundoplication. So I think as a surgeon, we have the responsibility to tell the people and educate about the surgery which can also be done in this disease. So the main aim of the surgery is that we have to restore the normal anatomy. We have to pull back the esophagus into the intra-abdominal. We have to create the floppy valve, and because with the medicines we can treat the acidity part, but not the structural component. So the thing is that when the patients are not getting better with the medicine and the symptoms are refractory to the medical treatment, I think the surgery should be considered. The one question to ICA Gowal sir and Piyush sir, so is there any difference between treatment of non-erosive GRD and erosive GRD?
Firstly, thank you. I'll just answer. Dr. Puri, thank you very much. We did not realize that it is a surgeon who is speaking, or it's a very learned, highly educated physician who is giving us talk about GERD.
Thank you so much, sir.
GERD is more likely a medical subject rather than a surgical problem, but you made us everything so clear. So GERD is basically correcting the anatomy, whereas we physicians correct the physiology, try to correct the physiology by giving benefit from acid secretion, but that does not affect anything in flux. Fundoplication appeared to be a very big surgery to us as a physician, and I feel that this could also act as a bariatric procedure to some extent, because the fundoplication means stomach capacity is also reduced to a certain extent. Does it act like a small bariatric procedure also?
No, no, sir. No.
You are reducing the capacity of the stomach, apparently.
Only upper fundal portion of the stomach, the part of the stomach which is above the G junction, that portion is being used for the wrap. The rest of the stomach is still available. In bariatric surgery, if we talk about sleeve gastrectomy, we say the total capacity of the stomach is 3% of the body weight. So if a person is weighing 70 kg, his stomach capacity will be somewhere around 2.1 liters. So in sleeve gastrectomy, the remnant sleeve, it can tolerate only 100 to 120 ml of liquid. So that much is the reduction in the volume, which actually translates into the body weight reduction. So this much amount of fundoplication will not be called as any sort of bariatric surgery.
I think that the erosive gastritis is more risky procedure, because that's a more risky disease to have, because that is the one which leads to Barrett's esophagus and increased incidence of adenocarcinoma. And non-erosive is medically maintainable to a certain extent. There, one thing I want to know, that if the person is having GERD and we give these PPIs for say 6 to 8 weeks or 12 weeks, then this will be a very, I think, a long continuation of the PPIs would be more advisable. What do you say about this?
The problem is, many patients, they do very well with the first course of PPI. Problem is of recurrence and relapses. So eventually, a person becomes dependent on PPI. So as I told you, patients who are taking PPI more than 5 years regularly on daily basis. There are people who in the city who are taking for them for years together, because they say moment we stop this drug, we have the recurrence of the symptoms. So these are the subset of the patients who should be offered first.
And these are the patients actually, if you taper these PPIs, because once you stop suddenly PPIs, after a long time there is hypergastrimia and there is transient increase in acidity. So what is there any suggestion, like once you want to discontinue PPIs, you can add H2 receptor blocker for some times?
Yes, sir.
And then taper.
I think Piyush Boswell is the best person to answer this.
There is no such recommendation of stopping them abruptly or transiently. But as sir said that one thing I would like to ask one question. Post GERD surgery, how much is the PPI requirement for the span of say next 2-3 years?
So we after GERD, we usually give PPI for 1 to 2 weeks only. After that, PPIs are stopped. And another thing is sucralfate. It is another class of drug which people are very fond of using, especially this GERD patient. And we have to continue this drug in the post-operative period also for 2 to 3 weeks. Gradually we stop this.
So our message basically is that whenever patient is having a complication of GERD, he should be referred to a good lab surgeon.
Yes, what is complication?
Ma'am, any
Yes.
comment?
I think a manometry can be done. Normally, look at the endoscopy is normal.
So one more message for us physicians is that just because an endoscopy is normal, don't take it. Think beyond. Think of manometry, and then also if it doesn't respond, then think of,
Very good. And
because
especially
there are so many people, patients ENT के पास जाते हैं, physicians के पास जाते हैं, बेतहाशा महीनों तक एंटीबायोटिक खाते हैं, the cough doesn't go away.
ENT people have a huge OPD of reflux laryngitis.
Yes.
What is the recommendation for anti-anxiolytics
In patients
in
with
patients with GERD?
Yes, stress is one important factor which leads to this nocturnal escapade. So patients who are not being treated with standard PPI, you can have this anxiolytics, but as such there are no recommendations in the literature where we are combining PPI with anxiolytics.
We have found very useful in our practice when these such drugs are not responding very well. When a patient sleeps for a longer duration, generally he has less symptoms of GERD.
Or it is the other way around. When the
That
symptoms
is
are
functional
reduced,
dyspepsia.
yes, those are patients of functional dyspepsia. Or it is the other way around. When the GERD is not happening, the patients they sleep better.
I think manometry should be used more often.
Yes.
Manometry in association impedance, not alone just manometry.
Yes, with impedance. Because I told you simple food reflux will not be picked up by the TS manometry alone.
You mentioned many tantalizing tangential things also.
What is it?
I'll come. Japanese have the highest rate of gastric carcinoma,
Yes.
probably because of smoked
Yes, smoke, fish and all.
fish and whatnot. We basically have focused on the anatomical correction.
Basically,
What is also required is the physiological and the microbiological correction also. And that is the reason why vagus nerve is not cut.
yes,
Because it is
vagus nerve.
80% afferent and just 20% efferent. Maintaining a bidirectional, and even you said after 5 years of PPI, they'll end up with stenosis. So we have to be very mindful of maintaining a gut eubiosis.
One more thing, doctor, with the availability of DSR combinations with domperidone, I mean, think that is probably spoiling the treatment by, we see the prescription in which the DSR medicines are prescribed twice daily. So, what do you suggest for those patients who are taking domperidone 30 milligrams twice daily for such a long time? I mean, there should be a proper guideline for domperidone.
Basically, all these American, whether we are talking about American gastroenterology guidelines or Japanese, none of them they are mentioning combinations. So it is only PPI or prokinetics. These combinations are offered by the pharmaceuticals, and most of the times we physician and surgeon also forget about the
The US FDA does not recognize combination.
Yes.
मैं ये अभी तक पीपीआई की बात चल रही थी, तो पीपीआई में सर मोस्ट इफेक्टिव पीपीआई आई थिंक एस्मोप्रोजोल.
So if we talk about different literatures, dexlansoprazole has been published in the books that it is one of the best PPI. But there are studies which have compared omeprazole with the rabeprazole. They are not talking about dexlansoprazole at all. So to me, all PPIs, they are effective of the same tune. There is no superiority or inferiority over one or the other. Yes, for acute bleeds, I will say pantoprazole does the best. And for the persistent or abolishing the nocturnal breakthrough, dexlansoprazole is one of the best PPIs, followed by the rabeprazole. Which was, let me correct if I am wrong.
Now recent PCAPs.
PCAPs, yes. PCAPs have come up. We don't have any long-term data, Indian data.
Yeah.
So we are waiting for those studies on Indian population.
Definitely.
Helicobacter pylori, it's a bacteria which leads to hyperacidity. As such, there is no direct correlation of H. pylori with GERD, but yes, patients who undergo endoscopy and we do RUT, if the RUT is positive, obviously the first step is to treat the Helicobacter pylori. It goes without saying. If we find the evidence of H. pylori, the treatment is possible.
Pentocid is one drug which is recommended with clopidogrel to a large extent rather than other PPIs, because that is supposed to be a better combination as compared to other PPIs as far as the effect by the same mechanism.
Thank you. Thank you so much. Thank you. I request President ma'am to present mementos to speaker and chairpersons and panelists.
Thank you so much. First, I would like to express my heartfelt gratitude to all my beloved esteemed IMA members. For your enlightenment, I would like to tell you that this year it has been a record of more than 32 to 36 scientific CMEs we have conducted throughout the year in all specialities, particularly for physicians as well as super specialists. And at this point of time today, we are on the verge of completing our tenure, and today was the last scientific CME. First of all, I would like to thank our program coordinator, my joint secretary, my beloved younger brother Kirti Vardhan Singh. I would also like to thank my sponsor, Sun Pharma, Sun Division, Pentocid brand, particularly very dear Prayag Teet and Mr. Amit Kumar. I would also like to thank eminent speaker for his words of wisdom, very crisp, very informative talk, and of course, our respected chairperson, Dr. Piyush Mishra sir, my chairperson, scientific subcommittee, respected Dr. A.C. Agarwal sir, who also happens to be our past president, my panelists, Abhinav, and thank you audience for patience hearing. And once again, and the renowned gastroenterologist, please give a huge round of applause to my elder brother, Dr. Piyush Mishra sir. शक्ल भी मिलती है, कुछ लोग बोलते हैं पीयूष बहुत से. And lastly, I would like to thank on behalf of Honorable President Ma'am Dr. Nandini Rastogi and Dr. A.C. Agarwal sir, Chairperson Scientific Subcommittee, to my Scientific Secretary Dr. Ganesh Shankar and Joint Scientific Secretary Dr. Kirti Vardhan Singh. I request the audience to please give a huge round of applause. आज जितने भी हम ये CMEs कर पाए ये इन्हीं की बदौलत है. Thank you very much. And we also have our incoming President Dr. Anurag Mehrotra sir, who happened to be the Chairperson of AMS Academy of Medical Specialties, और उसमें भी रिकॉर्ड इस बार मेरे ख्याल से 5 से ज्यादा हम लोगों ने वो किए, और वंडरफुल, चाहे वो ट्यूबरकुलोसिस वाला हो, चाहे वो HPV वाला कितना अच्छा अंडरस्टैंडिंग वाला था, रीता मैम वाला किया था. तो प्लीज गिव अ ह्यूज राउंड ऑफ अप्लॉज टू डॉक्टर अनुराग सर एंड हिज काउंटरपार्ट डॉक्टर गौतम दत्ता. थैंक यू वेरी मच. जय हिंद, भारत माता की जय, लॉन्ग लिव IMA. I invite you all for dinner. Please come.